Welcome to our YouTube channel of Trishla Foundations. Lots of video has been uploaded on our channel, and most of the videos are educational videos for our parents, our therapist, our educator who is working with cerebral palsy children. Today I am concentrating on one very important topic, that is diplegic spastic cerebral palsy. Diplegic spastic cerebral palsy, the commonest variety of cerebral palsy, and in that cases, diplegic is very important. And most of the time, these children need proper therapy, but most of us like to know when they need orthopedic surgery. So in this lecture, I am taking the scenario where these children require surgeries. In diplegic spastic cerebral palsy, lower limb are more affected than the upper limbs, and usually they are walker. They can have GMCS 2 or 3, but rarely GMCS 1. Sometimes they can be GMCS 4. In the diplegic spastic cerebral palsy, you can find different types of the gait patterns. They start with the commonest gait, that means toe walking, then can go in the jumping gait, that means bending the knee and equinus at the toe, and ultimately they have to go in the crouch gait. Crouch gait means they are walking with the bent knee, but foot is completely at the ground. And sometimes there can be asymmetric gait patterns. One side have the equinus, other side have the crouch problems. You have some other problem like noticeable deformity is there. You can see on the screen that child with the equinus that convert to the crouch gait in long terms. What they need? Most of the spastic cerebral palsy children need the good quality physical therapy, intensive therapy programs along with the braces like FO, FRO, gaiter, walking aid like the e-stick, elbow crutches, walker. And along with that, the training and activities of daily life is the very important in overall management of cerebral palsy children. The orthopedic surgery has only some role where the child develop the deformity or joint issues. The indication of orthopedic surgery in diplegic spastic cerebral palsy is the fixed deformity of the joint, if they develop torsional deformity of the bone, if they develop the muscle shortening, joint dislocation and arthritis. But goal of surgery is totally different in two group of children, walker and non-walker. In walker, our goal is gait improvement. In non-walker, thus only the surgery which make them comfort with the transfer and wheelchair sittings. When they require surgery, when we can go for the surgery, there is no age limit. But usually in diplegic spastic cerebral palsy, you should avoid this surgery up to the age of 7 to 8 years. Why? Because gait is not mature till that times. But rarely in some cases where joint dislocation is there, adductor contracture is there and severe deformity, then they have to go surgery, and even at very early age. Commonest age of surgery is 8 to 11 years and retuning surgery between the 12 to 15 years. And after this maturity, sometimes they require the surgery, but very rare. What are the prerequisites? Which children can go for the surgery? Where we can think that the results of surgery will be very good. They require good family support. There should be backup the physical therapy programs. Intensive therapy should be there. Otherwise, surgery has only one part of the treatments, and 90% role is physical therapy. So, backup of physical therapy is very important. Child should have a good general health. Intellectual disability should not be there. If there, it should be only mild. Because if the moderate to severe, they will not cooperate in the rehabilitations. Child should be motivated. Child should have good functional capability, like using the upper limbs, regarding the IQ, regarding the transfer from one place to other place, regarding crawling and knee walking. And aim of surgery should be very precise to the consultant as well as for the parents. Now, point came that how to proceed. For proceeding toward the surgery, detailed evaluation by the therapist and orthopedic surgery is mandatory. In the evaluation, first The history should be taken prior to everything to see that what was the cause of the insult, how it happened, it is not genetic cause, what was the functional capability was there, when they start standing and walking, what functional capability at what age, and after taking the history, we should have physical examination in supine, in prone, in sitting, in standing position, and all this finding will be confirmed by the taking the gait analysis. We do gait analysis just by the video gait analysis. The video is taken in slow motion video from front, side, back, and we evaluate that. And sometimes we require radiological analysis in the form of X-ray of the hip, X-ray of the knee and foot, sometimes CT scans. And whatever we have got the finding, all these findings should be confirmed during the anesthesia just before the surgery. Because sometimes child is not cooperative, we cannot assess what kind of deformity and actual deformity is there. In gait analysis, we have to check from front, side, back. In the Diplegic Cerebral Palsy, when they need surgeries, what the problem that require the orthopedic surgeries? In that problem, equinus gait, crouch gait, plantar valgus foot deformity, scissoring, and hip subluxation is commonest problem in the Diplegic surgery where they need the orthopedic surgery. First, I will discuss about the equinus gait deformity, that means toe walking. Toe walking should be confirmed that gastrocnemius muscle is tight or not tight. There should not be apparent equinus because of the crouch gait. That doesn't require any surgical intervention. Even in that case, in Diplegic Spastic Cerebral Palsy, most of the time we try to save calf muscle because calf muscle is going to lengthen naturally. If really they require, we need to operate in upper part of the calf, not in the lower part of the calf at the heel card. Because lengthening of the heel card 1 cm give 50% reduction in the power. It can lead to the crouch gait. In Diplegic Spastic Cerebral Palsy, we never do any TV lengthenings. We can see in the two videos on the screen, one child who is walking with the toe walking, now after surgery he is completely independent. Other child with jumping gait at the age of 9 years, he undergone surgery on both calf muscle at upper part and hamstring muscle transfer. Now he is in totally independent. Now we will discuss the crouch gait. Crouch gait is the most commonest pathology in cerebral palsy, and it is always in the downward mode, if not intervened at time. Earlier we always think that hamstring muscle shortening is the cause of crouch gait, but after research, after long work all over the world, that is determined that crouch gait has multiple etiology. Most important is poor motor control, and etiology start from foot to hip, plantar valgus fit, external tibial torsion, high patella, femoral torsions, hamstring shortening, fixed flexion deformity at the knee joint, weak muscle at the calf and hip can cause the crouch gait. Crouch gait, sometimes it is preventable because sometimes it happens because of the surgical intervention or therapy. So we need to avoid the TA lengthening or stretching. By that, power of the calf muscle can be maintained. If child develop the crouch gait, at earliest they should be given solid F4 FR with strengthening of anti-gravity muscles, and there should be early intervention to prevent the progression. As I told you, hamstring is not the cause in every cases. Some cases as it is there, and but over lengthening of the hamstring muscle can cause two problems. Knee can go on the back side, that known as the neurocurvatum, and pelvic tilt can occur. That cannot be corrected by any means. If it is really short is there, then hamstring muscle can be lengthened by the three methods. One is tendon lengthening, second one is the myofascial lengthening, third one is the transfer from the below the knee joint to the above the knee joints. And most important in the transfer is the power of the hamstring muscle and pelvic tilt can be prevented. You can see on the screen one case where child was walking with the crouch gait. Now after the chest hamstring lengthening at the age of 7 years, now he is totally independent, no knee bending is there. Another case with a similar problem, who is walking with the knee bending, and now with hamstring lengthening he is walking with independence. Another case who is 9.5 year age groups, walking with the bend knee. He undergone hamstring muscle transfer from below to the knee to above knee, followed by the intensive therapy for 5 months. Now is fully independent. Another case is also having the same problem, look like the commonest gait, but nothing done in calf muscle, only at the knee joint. There is a transfer of semitendinosis followed by the plaster. Now after 6 months of therapy, he is independent. One other child of semitendinosis transfer, crouch gait. He also had got good improvement. Now he is going to school, independent and managing every activity by his own. Now we are going to tell you about the foot problems in crouch gait. Crouch gait is also going to cause plantar valgus pain. Depending upon the severity, depending upon the age, depending upon the geometry scale, what other problem is there, they can be managed by the different approaches. Lateral calcaneum lengthening, fusion, subtalar orthodesis, and ultimately triple orthodesis in very rare cases. One case here I have shown here, the severe deformity foot is there. Now after correction of the foot deformity, he is becoming independent. Another case of foot deformity, again he has managed by this surgery, and now he is walking with the walker. Next problem is the femoral and tibial torsion. Femoral torsion means thigh is rotated inside, tibial torsion means external tibial torsion is common in cerebral palsy. Both problems can be managed by cutting the bone and fixing with the plate. That is, beautiful correction can occur. One child I have shown in this video that you can see that child was walking with inward gait. Now after surgery and fixation with the plate, he is independent, walking in straight. Another case with lower tibia problem, external tibial torsion was there. She also undergone the surgery and now is independent, and he also had the flexor deformity at the knee joints. For that, we have done the screw fixation of the anterior part of the distal femoral physis. Now come to the problem of the flexion deformity of the knee joints. Flexion deformity of the knee joint, it can be detected at very early 10 to 14 year age groups. In that age groups, you can pass the screw and managed by the growth modulation. As his age will increase, deformity will disappear. But in age is mature, is adult, then we need to cut the bone and fix with the plate after correcting the deformity. One case scenario I have shown here is 18-year age boy walking with the crouch gait. After surgery, fixation with the plate is independent. Another case with similar problem managed similarly. In that case, along with the femoral osteotomy, we also shorten the tibial tendon, patellar tendon also was shortened, and now he is independent. Another case with a similar problem, supracondylar osteotomy of the distal femur and patellar tendon was shortened, now he is independent, walking with the elbow crutches. Now come to the high patella, that is the patella alta. It is the common problem in the crouch gait because with the pulling of the patella upward, the child will not able to extend the leg. We need to pull patella downward. Patella can be downward pulled by taking the bony fragment at the tibial tuberosity distally, or sometime shortening of the patellar tendon can be done. In one case, what you can see on the screen, the child was walking with the crouch gait. Her tibial tuberosity was moved downward, and deformity at the knee joint was managed by the supracondylar osteotomy distal femur. Another case, this child is 25-year-old adult in the severe flexor deformity at the knee joints, high patella. In that case, we managed by the osteotomy of the distal femur, and the patella was taken downward by shortening of the patellar tendons, just reaping of the patellar tendons. And now come to the problem of hip subluxation or dislocation. That is a very common problem, or that should be identified at very early age. As you know, with increasing GMFCS level, means if child is not able to stand and walk, the chances of hip subluxation or dislocation are very high. 69% GMFCS 4, 90% GMFCS 5, and the subluxation of the hip can go into the painful hip. That means subluxation can lead to dislocation, followed by the start of dysplasia, sometimes femoral head damage, and ultimately hip joint arthritis. That will be very, very painful. So hip surveillance is very, very important. That can be done by the regular clinical examination of the hip abduction and X-ray pelvis. By that we can identify hip subluxation at very, very early age. Hip subluxation or dislocation can happen, then it should be managed by the growth modulation of the proximal femur or osteotomy of the femur, acetabulum, reconstruction of the acetabulum in hip joint. That is required. In one child, what you can see on the screen, the child is when she was 4, she was not able to stand and walk, bilateral hip dislocation was there, both sides hip was reconstructed, now she is walking with the walker. Another child of 18 years age, the one side dislocation, left side hip dislocation was there, osteotomy and hip reconstruction were done. Now after surgery and therapy, he is independent walker. Now come to the point of seizure gait. Seizure means crossing of the leg one each other during the sitting, during the standing, during the lying down position. It happened because of 3 reasons. Adductor muscle present inside of the hip joints, medial hamstring muscle that is present behind the knee joint, and hip subluxation. And in that case, one case I am mentioning here, you can see on the screen, the child never able to stand, never able to sit down, her leg was very, very problematic, crossing, hip joint was subluxation, hip joint operated, another joint was, screw was passed, now is able to sit and stand with supports. And ultimately, last, I want to say that surgery should be avoided till the age of 7 to 8 years. Exception is there in the cases with hip subluxation and dislocation with severe deformity. And before planning of the surgery, surgeon should know detailed evaluation. They should do detailed evaluation including physical exam, gait analysis and reanalysis just before the anesthesia. And in all the cases, we require the good backup of intervention therapy program. That should be very intensive therapy. The therapist should be trained in cerebral palsy management. And whenever we go for the surgery, always we try to manage every deformity in the body. We require orthopedic surgery in single setting, that known as single level multi-level surgeries. Crouch gait and pelvis tilt can be prevented by not doing surgery on the tendoculus, heel card, and not doing the vigorous stretching exercises. And we try to do minimal muscle surgery as much as possible. Mostly we correct the deformities by the bony surgeries. But for the parents, it is a long-term follow-up is mandatory. With aging, problem can reappear, new problem can happen. This was the whole talk on what is the role of orthopedic surgery in diplegic spastic cerebral palsy. But most of the diplegic spastic cerebral palsy and other children are going to be adult one time. We are going to start our very, very awaited webinar, Effect of Aging on Cerebral Palsy Individuals. As you know, the normal individual has to go aging. They will have effect of aging at the age of 60, but in cerebral palsy they will start the effect of aging in 35-40. Some children, they are walker before the age of 15-20. Now they are wheelchair bound. So everyone should know what the impact of aging. On that topic we will start the webinar that will go for 6 months. So please don't forget to attend that webinar. That will start on 18th November every Saturday at 7 p.m. Lots of videos available on our YouTube channel. Go through, see it and like our channel. Thank you.